I don't know
This
about,
meeting is being recorded.
I don't know about others, but I had absolutely no idea the procedures as far as my surgeries or anything were done. All I know is I had them.
Yeah.
Yeah.
Well, it depends on when you have them done as to how they would have done them. So
Wow.
When did you have it done, Burl? When you were very young?
I was about 19, no, I was
Yeah.
about 17, I think, 16 or 17, I had my first operation.
Oh.
that
And
might
I
have
was
been the
19
old
when they
style.
After the war.
So I am going to put Tootie and Eric on spotlight.
Uh-oh.
Uh-oh. We welcome you, Eric. Thank you very much for coming back here and having a chat with our members here. We're very happy to see you,
Thank you.
and I think we all have some very good questions.
Hopefully I can answer them.
Oh, I think so. You did very well the last time, and we were so happy to have you back here. Everyone asked, and we've all had so many types of operations. Many, as you just heard, we had no idea why we had these operations or what they were. For example, I had an operation on my left heel, and a button was put in. And I don't know why there was a button, but I saved that button for a very long time. And I have a scar, I guess it's about 3 inches long at the very back of my Achilles tendon.
Achilles tendon lengthening.
A lengthening?
Yeah, usually it's well, it depends on there's two ways to do it. Usually there's two muscles that are attached to that tendon. One is the gastrocnemius, which goes between the femur and the calcaneus, the heel bone. And then the other is the soleus, which goes only from the tibia to the heel bone. And so and it's typically the gastrocnemius that's a little bit tighter. And so usually you end up having to do you can do a partial lengthening. And it really depends upon which muscles are tighter, if they're similar tightness as to how you want to do the tendon lengthening. But usually that's what happens is your foot goes, your ball of your foot goes down. You can't get it elevated, and therefore you can't actually put your foot down. So you have to lengthen the Achilles tendon.
Okay, and it's been perfect for, I would say 60 years, but
Yeah,
lately.
Once you're an adult, it's pretty much stabilized.
Yeah, but lately, I guess I was pushing my foot down and I've got a very sore Achilles tendon. What do you think I should do about that now?
Oh,
Well, you probably should see your doctor, whether orthopedist or your PCP. If it's painful, you may have Achilles tendonitis, in which case you might want to, you would probably get treated with some sort of a brace for a while. But you really you have to research it. Usually an MRI will be good enough to figure that one out.
Okay. Well, thank you very much.
well,
I
don't
see
thank
that.
him till you're sure it's correct.
Well, you're still going to need to see somebody who's going to order that for you and things like that.
Yeah,
And you should be seeing, and you're in Canada, right?
yes.
So, not that I know a lot about their system, but they're still optimally you'd see a foot, ankle, orthopedic doctor. But for a regular Achilles tendonitis, you could probably see most any orthopedist.
Okay. I see that Maureen has her hand up.
I was short on words. So Eric, Dr. Eric, whatever,
Yeah,
Pleasure to have you here. So my,
thank you.
well, my question is, I had 2 triple arthrodesis, D-side, whatever the plural is, on each ankle. And
Hind foot.
I'm sorry,
It's really the hind foot. That you get the ankle, the subtalar, and the show parts joint are fused. So the triple is the 3 joints: ankle,
Yeah.
subtalar, and show parts joint.
the way they said it to me, they said they break 3 bones. My right foot, I was walking like this, and I had a drop foot. So they picked this up, they straighten that out, and then they
Right.
protect your ankle from rocking and rolling. So those were done back in the 60s, I think a year and a half apart or something. And the left leg never left a brace, and the right leg left a brace up until the early 2000s when the triple failed on my right ankle.
What do you mean by failed?
Well, my foot is dropped again. That's what I mean by failed. No pain, but it's not held up anymore. So
Have you had X-rays?
excuse me,
Have you gone for X-rays?
to see what happened to the ankle? No,
Yeah.
no.
No?
But my question is though, what would make one ankle still stable after all these years and the other one, in my words, fail?
How old are you?
71.
Okay, so
Don't say old age either.
no, it's most likely osteoporosis, but because you have a combination, you're female, you're 71, so once you stop producing female hormones, you start going. The menopause also creates the stimulus for osteoporosis, and then the fact that you're also a polio victim and required these surgeries at a young age, so you weren't really doing a lot of walking, probably, or at least
Walked everywhere.
you walked everywhere.
Everywhere.
Well, all I can say is that chances are the most likely diagnosis is what's called a insufficiency fracture. So when you fuse the hind foot joints, including the ankle joint, that leaves the mid tarsal and the forefoot joints to take up all the motion, and probably your knee joint as well, depending on what's going on. So you've created a block to motion at your ankle and hind foot. And so what happens is the other joints start moving more and more over time. And because of you're pushing them but when you get osteoporosis, you end up with the bones become weak enough that you can actually break them by just forcing them. You hit hard, or you're pushed off hard, or any combination of things can create a fracture. And then because maybe it doesn't hurt because one, it's not very oftentimes they're not that painful because of the poor bone quality, or possibly I guess polio doesn't really affect the sensory nerves, but you may have other sensory things going on, like it from your lumbar spine. So that I'm not sure how your sensory perception is. But
I feel everything from head to toe in all places.
all right. Anyway, I would definitely urge you to consider seeing somebody for some X-rays, because it's going to be either something going through a joint, such as either a subluxation or a dislocation, or an insufficiency fracture, or a combination thereof. Otherwise, it should be stable. If it becomes unstable, it's going to be due to some sort of a combination of those things.
Well, what are we going to do about it? I'm not
Well,
looking.
she's got to see her doctor
But
and get X-rays.
the end result, I'm not looking to fix it. Yeah, it's floppy, but who cares? I'm not walking.
Well, you could brace it, obviously, to hold it together,
Have that.
and then you could just do it that way if you want. But It's up to you, obviously, how you want to do it. But if you want to know what it is, then you're going to have to see a doctor.
Right, I was just wondering what, just what would make it fail as opposed to the other one not failing.
Yeah, it's like I said, it's either good because you have when you have that fusion, the 3 fusions, you end up then forcing the other joints in your foot and sometimes even your knee joint to take up the slack for motion. And if you so either you're going to force one of your foot joints to move too much and then becomes floppy, or especially if you say were walking around a lot, so the bones probably didn't get super soft, in which case it's more likely the joint, but because of your age and other things, it still could be a bone in your foot. And then if it is a bone and you kept walking on it, it would create a fake joint. It's called a pseudarthrosis.
Is that the same premise, if I may? I don't think it's out of your wheelhouse here, but when they do, what do you call it? When you put the cement in between each of the vertebrae, what's that?
Oh, you're talking about so you're
What do you call
you
that?
doing when you have a compression fracture,
Yeah, what do you call it?
osteoporosis.
Kyphosis?
You can either put a balloon in and then blow up the balloon, expand the bone, and then inject the bone cement. Methyl methacrylate is what it's called. Or you can, depending on the quality of the bone, you may try to put a big needle in and expand the bone by pushing the methyl methacrylate into the bone and letting it hard without the balloon.
Well, what I was trying to, if the word is assimilate between what you said and what I have in my mind, that my mother had her spine collapsed. So I forgot, kyphoplasty maybe it's called, where they
Yeah, so
so
because of the anterior compression of the bone, you get into what's called a kyphosis, which is a sharp, well, it means a curvature to the back, but if it's a sharp kyphosis, you might even call it a gibbous. But so kyphoplasty means that you're elevating the front of the bone so that you're relatively trying to straighten it back out to a normal curvature.
right. But I remember I said to my brother, maybe I even asked the doctor, I said, the mere fact that one that you're injecting that cement in and it's going to be so strong, is that going to weaken the area around it because this is so strong? And his answer was no. So I'm thinking with your answer to me about my ankle, and my mom kept fracturing anyway all around where they put that cement in. So I'm thinking that what I logically was thinking about her surgery was correct, that this was so strong that everything, around this strength right here kept fracturing, just like my ankle. It was so strong, at the time, and then and then it fell apart.
Well,
So-
you have the concept is correct. Unless you broke through one of the fusions, it's going to be, like you say, it's going to be typically it's going to be either in the midfoot, like the arch area, or just past that, or even at the next joint out is called Lisfrank's joint, between the hind foot and the forefoot, and that's a easy area to injure, and can cause a lot of. You're lucky if you did whatever you did, it doesn't hurt. You're lucky.
Yes, absolutely. And it's not, for me, if it's not broke, don't fix it. It's not broke.
Well, it is. Something's broken, but
It's okay. It can
if it's not bothering you, so that's your answer.
Thank you. Next.
How about Marcy? Do you have a question?
Well, I could ask a question. I've kind of blew what was my better leg. So I have a torn ACL and a torn meniscus and that. So they're not going to do anything about it. I just wear a brace. But what I always thought was very funny is I had 2 different doctors ask me if I wanted to have my knee fused. And I was just thinking,
Well, that's because you must not have they would only fuse it if you didn't have very good muscle control.
I don't have, no. And,
Yeah, yeah.
but I mean, I just couldn't think about, getting on a plane, getting in a,
Oh, yeah, that would be really awkward.
yeah, so I just thought that was so I just live in my braces and my chair, so.
Yeah, yeah. You have a locking braces then?
No, I don't.
Oh, really? Okay. Well, you
No,
must have some
actually-
muscle control then.
Well, I have muscle control around it enough that I can lift my leg up and I can, kick it out, but it
Yeah,
wasn't enough leg control to keep it from hyperextension.
right. Yeah,
So it's really awful hyperextension. And so, I mean, basically I just live with it because nobody really wants to do anything about it. So,
well, there's a lot of complications. Nobody wants to do something that causes worse problems for you.
but what I tell you, what I have had done with my braces, to keep it from hyperextending as far back as
Right.
on my braces, I have like a sling strap. So it goes,
Okay.
and so that, and I do that really tight. So it keeps that, and so that kind of keeps me a little bit more comfortable.
Right. So you have problems. That would suggest that, let me think. So can you stand up straight?
Well, I can I can't really walk around. I mean, I can stand
Yeah.
up. Yeah.
So it ends up being that, however, you may even have a little, does your ankle come up? Or do you end up it's still sort of going down a little bit? When
No, actually, I would say the other parts of my leg are just fine. It's just the knee area.
Well, usually that means that for whatever reason, you're using the posterior ligaments to help support you rather than the muscles. And over time, they just slowly gave out type thing, which is why you're having to brace it and support the posterior ligaments.
Right. I think I just overused it totally. Yeah. It was my workhorse. So
Yeah.
thank you. I just wanted to throw that out at you. Thank you.
It is very interesting. Who has the next question?
Roland has his hand up.
How bad does polio affect the lungs?
What?
How does polio affect the lungs?
The polio virus doesn't affect the lungs per se, but what it does affect is the muscles. And because you need the muscles of your chest wall to expand, to rotate the ribs, and by doing so, it's sort of like the 12 ribs are lined up like bucket handles, if you will. And the muscles then bring it from down and they raise it up. And that then opens up the chest wall, which creates there's basically a vacuum holding the lungs to the chest wall, like a suction cup type thing. And when the ribs open up, then then allows the air to come from through your mouth or your nose into the lungs. And so if you don't have, that's why the old iron lungs, that was what the purpose of those was for, is because the muscles weren't working, and the old iron lungs then lifted the lungs, the rib cages, to then expand the lungs, allowing you to breathe. Nowadays, people use where you're intubation, so you get intubated and they pump the air in.
Okay, because I had a heart attack 6 years ago, and after my heart attack, the whole body started to. I see you, adios, goodbye. I had no use of my arm when I was a kid. I don't know if you can see. Maybe if I back up. This is as far as I can bring them up or bring them forward.
I can't see. All I see is myself, kind of, and my mom.
Okay, from the elbow to the shoulder, there's no muscle. Okay, from the elbow to the shoulder, there's no muscle.
Okay.
So I can't scratch my head. If I scratch my head, I have to put my elbow down and then put my head down and scratch my
Okay,
head.
so you don't have a biceps?
No, zero.
You have a triceps?
Nope.
Okay. Well,
So But my main concern is, like, I used to play golf 4 times a week and walking. And
Wait. So are you saying that you used to have a biceps?
a little one, not much, a little one.
Okay.
After my
How did you lock your elbow for the swing?
aha, it's a one-shot deal. Do you remember they say stop at the top? Forget that, baby. You go to the top, then the whole body comes. The swing is not the arm. The swing is the body.
Yeah.
Okay, that's all.
You'll have to hold your arm still enough that you can, when you strike the ball. So you're saying what basically the momentum of the swing allowed you to okay.
Yeah. So, and what prompted me to play golf is Lee Trevino. He says, anywhere you can hit a ball at 150 straight, there's not a golf course in the world that you can't par. And that stuck in my head, and I done the math on it, and it's true. So that made me positive to play. Hey, I went there, and every time are we playing for a 2-door fridge today? If yes, I'm not playing. If we're playing for fun, I'm here. And that's what I used to do.
Yeah.
But my heart attack, now I'm having problem with my legs. I had a little bit of problem with my legs before, not much. Only like if I was on the side of the hill, my right leg mostly, like in my mind, my foot is going forward. I'm sorry, the foot is still back there. I'm falling on my face. I remember I had that when I was a kid. Like from the age 5 to, I say, to 10, you go look in my closet, there's not a pair of pants that don't have holes in the knees because Rolly would fall down.
So there, you do know that polio victims have later in life will have sort of recurrence of their problems due to the muscles sort of wearing out.
Okay, that's all news to me because when I grew up, polio, we don't know what that is. You go see the doctor and say, oh, I had polio. I see. Yeah, you had polio. Stop talking about it. You had.
This is sort of a newer realization, I guess you could say, that polio victims in later life have recurrence of the things that they had early on.
That's why I talked to my doctor.
Basically given out.
I try to educate my doctor, and when he sent me to the rehab, I went there twice, and the second time I almost insulted her because she saw me again, and she said,
"You might want to try a neurologist."
Oh, I'm sorry, a what?
A neurologist.
Uh-oh, I got to write that down. I got a good memory, but it only lasts 15 minutes.
Well, the only way you can really tell what's exactly going on is a neurologist. One is trained to do the evaluations for those things, muscles, nerves, different things like that. Okay. The other thing, though, is that if it could be that you're having a problem with your back that's affecting the nerves of your legs. And so you want the neurologist to do the workup to figure out what's going on, whether it's just a problem with your old polio coming back, or you have new problems that also need to be looked at and maybe treated. Yeah, because I remember when I was a kid, nobody believed me I had polio. Even one teacher told me the day I can raise my hand properly, she'll ask me to answer the question. But I was in gym and they said, no, you have to. I said, I can't do it. Yeah, go up. And I fell right on my spine. And they said, oh, well, maybe next week you should sit it up. Right. Get frustrated. If you've got a few falls onto your spine, you could have, arthritis develop or herniations of the disc, things like that, or combinations thereof. And over time, many people, the people that I see have all been injured. I no longer actually treat people. I evaluate them for work injuries, basically. And so I see most of, a lot of them are older, arthritis is set in, things like that. And so I see a lot of people with low grade spinal injuries, or even, over time as what's called stenosis develops. And so the nerves are getting pinched slowly over time. And whether or not how much it is affecting you, pretty much only a neurologist they're the best equipped to figure that out. Because I can't stand up now. I can walk, I can drive, but if I go to my grandson because he fixes his car and I tell him what to do. But if I'm standing for
a half hour. I said, I gotta sit down.
There you go.
Give me a
That's
chair.
usually standing for like a while and having things go out on you is typically spinal stenosis. It's a nerve, it's pinching the nerve in your lumbar spine. It's going to be either in the central canal or where the nerves come out through what are called foramina.
Can you
So-
do anything about it, or is it gonna be?
That's
like-
surgery.
Okay,
They nowadays that they do have really microscopic surgery. They can go in there with a scope and little burrs and things like that. If you find a place like that that's a good, then you could probably get away with relatively minimal types of surgery and have a pretty good result out of it.
okay, because like my legs, I cherish my leg all my life. Even
Yeah.
when I went for my heart attack, they said, we're gonna take a vein out of your legs. I said, no. They said, we have to. I said, that's it. I'm out of the hospital. I walked out. And then my doctor called me. He said, what the hell are you doing at all? You're supposed to be in Montreal. I said, they want to take a vein out of my leg and they're not
Yeah,
touching
but
me.
don't worry about the veins.
So
You can make your leg will actually make new veins. for
that's
you.
exactly what when the heart doctor called me. He said, I don't know why that guy.
Yeah.
I said,
If
No.
you need it, if you need the for your heart, you
Yep.
should really think about it.
So, but
A
they fixed
vein,
everything
a
else.
vein is very expendable.
Yeah, so,
It's very expendable.
okay. But
Okay.
nobody knew exactly, like, they did a mistake here in the hall. They called my daughter and they said, can we give your dad some fentanyl? And she says, very, if he gets hooked on that, he's gonna come and tear that hospital down. So, but apparently I must have had some bad reaction because they tied me up. My brother says, why
Well,
they tied
yeah.
you up? Because
Some narcotics actually cause hallucinations and stuff.
my brother says I'm in the hallway, butt naked,
Yeah,
to
exactly.
the elevator, and they asked
No,
me
no,
what I was doing.
I-
I told them to shut up. I'm going home. So,
Yeah,
you know,
no. I had a patient tell me that he watched a nurse murder somebody, and he was on morphine. And I go on, what's going on? And they're like, no.
apparently, I told my wife to untie me because the dry cleaner had called me. The dry cleaner was on fire. only like when I got out, I was telling her about that. She goes, "That's a dream you had." Oh, it's unbelievable what I had. I mean, one night I'm in Chicago.
Yeah.
On the Zamboni, going
those
on
are
the ice.
narcotics.
So, but nevertheless, is when they tied my arm, I couldn't lift my arm after the operation. I couldn't even lift nothing. And the guy says it's gonna take time, it's gonna take time. I was in there for 8 weeks. And then they transferred me here in the hall. And I said, the only reason why I'm here, you give me a needle in the morning and you give me, I'm going home. They go, you can't go home. I said, watch me. I am going home. And so they sent the nurse to my house. And that's the best thing I ever did. Montreal is like you're in Taj Mahal. And then the first thing you know, you're in the boondocks in Nicaragua and they don't even walk the damn floors in the hospital here in Hull.
So I'm not sure what medicine I think has gone down. I don't, maybe I lived in a good time for medicine, but people don't really seem to care as at least what I felt that they used to.
Yeah, they don't.
And it's kind of discouraging to watch. Like I said, I don't treat people, but I get to look over other people's work to see what they're doing. And I really, overall, at least in California workers' compensation, it's sort of piss poor as far as I'm concerned.
But right now, my biggest problem right now is frustration. I'm frustrated at everything.
Yeah.
My wife's having a little problem. And
Find a good doctor that you can talk to, which and nowadays with electronic health records is hard, but.
Roland, I will call you with a good name for you to deal, okay?
Okay.
Okay. Floor has been waiting a while. Floor, you have a question?
Yes, please. Thank you. Dr. Eric, I'm still ambulatory. I've always known myself to have weakness to my right leg. I have a little bit of foot drop during my early years. I used to be able to tippy-toe on my right weak leg, like a quarter of the way. I have noticed that since the last maybe 8 to 10 years, it slowly had gone down. At the last 2 years, I have not been able to do any lifting or it lift my right heel at all. I want to know if you can help me. What had I done? What muscles are affected? And is that gonna get any worse than what I have now?
Well, sort of what we were talking about with Roland.
Mhm.
The two factors of as you get older, for whatever reason, if you have muscles that were affected by polio, they can get worse again, even though they were strong maybe for quite some time.
I used to dance.
And then the other thing is similar. It's possible that you're having this type of arthritis in your back, this pinching the nerves. I mean, those are the two things that are, they're gonna, this, for non polio victims, the second one, I see that quite often. I hardly ever see a polio person.
Yeah,
except
I
you
had
guys.
an MRI of the lumbar spine, and there's a teeny bit in the L4 that thing that's going on.
L4, L5.
I don't know exactly.
Quadriplegic.
And I
Yeah, so
also
what I was
had
saying,
Quadriplegic.
you might be able to find a doctor that usually they're neurosurgeons that do these many operations with a scope. And I had one patient who had he had a lot of surgery and he has hardly any scars.
Over there. Thank you, Rana.
What?
Oh, Sanjeev, I'm gonna put you on mute. Okay.
I'm sorry. You were talking about neurosurgeon.
So
That can give
it's hard to say, but if you're losing strength in a muscle, there's pretty much, if it's not the muscle itself, then it's the nerve to the muscle. So,
Well,
and again, you might want to, if you check with a neurologist or somebody like that, they can do tests on the muscle to see what's going on with the muscle. And then
I
you
had
can
my
also do tests for the
neurologist.
nerve.
I had an EMG.
Okay, you did.
And
What did that show?
I did. Yeah, I did show I have neuropathy. I have to get back to him and discuss and talk to me about how the muscle weakness has to do with the findings in the EMG. But with this surgery that you are talking about, what are the chances? What are the percentage of? There's nothing to. I don't want to be able to tip it though. I just want to know what had happened and how bad it can get in the future.
What I was saying to Roland is that I actually, and I don't know, I don't know these doctors, so I don't know what their quality was to begin with, but I remember this one gentleman came in and he had a decompression, fusion, that kind of stuff. Then when I got another MRI, where the nerves go out from the spine, they were still tight. I was like, well, a long time ago, I used to do spine surgery, but I didn't, this was before all the new instrumentation. So once it became apparent that new instrumentation was required for spine surgery, I gave that up. But I was taught by some pretty decent people, I think. This is what you have to do to make a good spine after surgery. And it's just not being done like what I would think is a normal way to do it. So you need, find somebody that you can trust. That's the best thing I can tell you is it doesn't matter how you do it, as long as it gets done correctly and they don't do anything that would, so the shorter surgery is better because your heart, your lungs, and that kind of stuff. And a long surgery, you want to avoid that. So those are the things that you have to think about, complications of surgery versus the actual surgery itself.
Yeah. Another thing, I stopped wearing heels in my 30s because it's difficult, it's tiring, and it kind of falls off. So I'm still ambulatory. I walk pretty good, with flat, everything flat shoes and
And,
mostly
you know,
high top to support my ankle.
so there's also something, I'm not sure why I see it a lot, and I don't know
Mhm.
why I see it a lot, but,
Mhm.
and I write these reports, I say, look at these ligaments, they're loose. And
Mhm.
truthfully, in the almost 7 years that I've been doing this, and I see a
Mhm.
reasonable number of people with these ligament injuries, this needs an operation to tighten it up. And I have seen maybe 1 or 2 in
Mhm.
6 years where they actually do the surgery that I recommend. And it's just, in
Okay.
fact, I saw somebody just a couple of weeks ago. Not only is the ankle that she injured worse, but the other ankle, because I'm sure she's fallen a little bit off, you know. There's one ligament specifically that if you're wearing high heels, you're
Mhm.
gonna fall. And I actually had a lawyer that had really tall high heels. I said, it was a
Ooh.
deposition. I said, if you were this patient, you would not be able to wear your heels because
Mhm.
this ligament is torn. You cannot wear heels when this ligament is torn. You're going to fall off your heels. And that lady actually got her operation.
Oh,
But
good.
that was the only,
Oh, you're
I think
good.
that might be the
What
only
is the
time
name
I
of
ever
the
got an operation out of for this.
What's the name of the ligament, Dr. Eric?
I'm sorry, what?
What's the name of the ligament?
The anterior talofibular ligament. It's on the outside
Okay.
of your ankle.
Yeah.
And then I actually recently saw somebody, the deltoid ligament, which is the medial side of the inside part of your ankle, is
Mhm.
usually pretty good. But I recently saw somebody who had this thing almost 7 years, I guess she's been going with this. And I've been telling everybody, you got to fix the outside ankle. Well, now
Mhm.
the inside ligament is going bad also when you go down. So if she steps down, going downstairs on a step,
Mm.
her ligaments are going to give out on her. And so
Mm.
but I can't, I don't know how to teach somebody how to examine for ligaments. You're supposed to know that.
Yeah.
So,
Well, it's kind of unfortunate that I see my neurologist since 2006, go every 6 months. When he examines me, I can right away tell the changes was happening on my leg. But it's unfortunate that as it was going down, it was never discussed or offered to me that there may be a chance that we can prevent the worsening of the unable to tippy-toe. And this is the very first time I heard about it. And I thank you very much.
There's a brace, I always call it a figure 8 brace. You slip it in,
sir?
and it's got shoelaces like going up the front. Then it's got a strap from one side. You wrap it around the arch of the foot and pull it up to the other side. And there's another one from that side. And you pull it, do for the other side. And some brands will have a thing that wraps around the top to hold everything together. And if you wear
What do you
one
call
of
it
those,
again, please?
one of those will help you if you have wobbly ankles that you can't wear heels with.
No, I have no intention to wear heels. I'm pretty good with my flat shoes. Thank you so
Yeah.
much. Thank you. I
Thank you.
appreciate it.
Thank
Very
you,
good.
Lauren. Thank you very much. I have Wendy and then Lois. Wendy?
Okay, I've had arm problems and hand problems. And I just got informed from my doctor that it's all coming from my neck. My neck is full of arthritis. And I was wondering, has that got anything to do with the polio? I was paralyzed from the waist down. And I don't know. I know I got a bad spine too, but
Well, let me ask you this. Have you had a nerve test?
no.
Okay.
Oh.
Now, do you have numbness in your fingers or tingling?
Yeah, numbness and like
Which fingers?
shocks, like I'm getting shocks.
Yeah, but which fingers?
All of them.
All
Both hands.
fingers, both hands.
Both hands. And I use a walker.
Okay, well, all right. So when I see people with all fingers on both hands kind of stuff, you may have something going on with your neck, but there's also what's called the brachial plexus, in kind of from your neck into your armpit, basically. There's a lot of action of the nerves coming out of your neck that go eventually down your arm and into your hand. And in that area, especially if you use a walker and things like that, it's possible that you reposition your shoulders a little bit and can have a dynamic form of nerve pinching up in your shoulders. And then the other thing, the fact that you're constantly putting pressure on the palm of your hand there's two nerves that come into your wrist, one on the outside, one on the inside, and they're going to get pinched as well. And so realistically, as I was talking before, you should hopefully find yourself either a good hand surgeon or a good neurologist. They just look at the nerves. They don't do operations. But ultimately, so when I see people like this, you have to start looking at their neck, the shoulder area, the elbow, the wrist, to see what areas might have the nerve being pinched. And if you have more than one area of the nerve being pinched, then you create a situation where, and there's a term for it, it's called a double crush syndrome. And so the nerve starts off in your neck, and it's got a long tube that comes down as far as your fingertips for that particular nerve. It's called an axon, AXON. And that axon then is the message system from the nerve cell in your neck down to your whatever part of your body that it goes to in your arm. And if you have more than one area of being pinched or injured in any way, that nerve has even less function than you would expect from both of those added together. It's an exponential injury, meaning that it's not just additive, it's like multiplied. And so you can have even a nerve study. I've had people that have nerve studies and they say, oh no, it's normal. But it's like they can't feel, like you can stick them with a pin, that they don't flinch or anything. And so unless it's, some deep hypnosis kind of thing, they're living with these injuries. And the problem is that's sort of this double crush injury is a sort of a newer concept that it's reality. So you want somebody to be able to evaluate you from your neck to your fingers and figure out how many areas of injury do you have. And so the way I used to deal with that is if it was so for you would have a carpal tunnel maybe and an ulnar nerve at the wrist area, which is a pretty simple operation. Any hand surgeon should be able to do it relatively easily. And you're not going to have make a big deal about it. You start using your hand right away. But even your elbow is relatively simple as well. And there's one procedure that I recommended for that always, just because it was good. It stabilized the nerve and it protected the nerve at your elbow. And even if it took longer, it was the best, and that's what I did. But a lot of people don't do it that way. But anyway, and then you have to deal with things going on in the shoulder area, like I said, and the neck. And so, but if you don't have a bad injury in the neck and a bad injury in the shoulder, you can take care of a lot of it. Like I said, because these are multiplied, you can take care of a lot of it maybe by just doing your hand. Like I had the first time I ever saw this was a guy, I was sort of fresh into the business, and he had carpal tunnel, but he had so much pain and other things going on in his whole arm. And I did a whole workup, nothing else was really bad. So I said, okay, well, let's do the carpal tunnel release. And it took care of everything. So all I can say is, so that was my point of view from then on, is that if I found this kind of a condition, then I started at the hand and worked my way up. So that because they're easier, less complicated, and a good result is usually assured because it's a common operation. And everybody knows how to do it, and the rehabilitation and all that other kind of stuff. But anyway, that's how I would approach your situation, is you don't want to, because to have all your fingers have problems, that would require, so that C6, C7, and C8 all be bad in your neck. That doesn't usually happen. I won't say it can't happen, but it doesn't usually happen like that. There's usually a combination of something going on other than just your neck for those things.
Thank you very much.
Okay.
Thank you very much. Lois.
Hi, thank you. I had a hip replacement and I was told they could only do the posterior type. You guys don't do posterior. Anyway, I
I'm
still
sorry, say
hurt.
that again? You didn't like the posterior, or you want an anterior?
Oh, I'm still in pain, and it's not the bone on bone, but I still have pain. And sitting and listening, I'm thinking, you know, I know they went in there and rip stuff and do that. I've got an appointment to see a physical med doctor because good old Maureen
So
said I
where
need
do
to
you
get
have
the-
this pain?
Kind of in my gluteus maximus area, sort of around where the scar is.
Okay. Now let me add one more thing. Are you flexible or sort of stiff jointed?
I'm medium because I do some stretching.
No, can you show me your hand? Can you take your thumb and sort of with your other hand and move your, can you hold this, please?
Okay.
So can you do this kind of thing with your hand? I need to pull your thumb down. Pull your
That's as
wrist
far
down.
as
That's it? Okay,
that's as far as it
you're a
goes.
stiff jointed person. So
Okay.
I'm flexible. I can pull it around pretty good. And so what I've learned over time is I never get stiff. Even though I may get temporarily stiff, ultimately I get my motion pretty much all the way back. Okay. But people who cannot do what I do have lesser degrees of that ability. And assuming that you're doing what I want you to do, you're pretty stiff jointed. And so two things. One, you make great scar tissue, but unfortunately it can be too much at times. And I've had people, as I used to be a hand surgeon, and that's why where I really got involved in this concept was because if you don't watch out, a really loose jointed person, you have to keep them in a cast or something a lot longer to have all the ligaments heal up. For a person who's like yourself, you have very short periods of time because otherwise everything gets so stiff you can't ever move it type thing. And I won't say that that's what's absolutely going on, but if it's in your gluteus area, it's more likely to be some sort of a scar tissue than there's certain types of prostheses you get thigh pain or you have something, but typically then it's probably going to be some sort of scar tissue problem that, it may help to do rehabilitation for, and certainly that's the goal, but for really stiff jointed people, you might have to think about like a surgery. Now, for the hip, and I'm not really sure, where do you live?
I live in LA,
Oh,
California.
LA. Well, for sure, in LA, there's a lot of sports guys in LA, or sports specialists, orthopedic sports specialists. There's actually big corporations of orthopedic specialists in LA. And they would maybe to be able to scope your hip to release this, that, or the other thing kind of thing. If you need to get more mobility of your hip, I don't know what you have without evaluating you, but in the gluteus area, The other, does it, you ever have things that go down your leg from that?
Yeah, sometimes I was sitting here rubbing how, from the hip down to the knee, that's very tender. Sometimes.
So, yeah, so the front part of your hip, the femoral nerve crosses over in the hip front of your hip joint area. And in the back part, you have the sciatic nerve. So the sciatic nerve then would go from your hamstrings, the back of your knee, and then down the rest of your whole calf and your whole foot and ankle. But in the front of your leg is going to be the femoral nerve, except for a small component that goes through the skin to your big toe, basically, on the top of your foot, not the bottom. And so those are all part of the same nerve. And if it's going into the front there, you might have to think about seeing a sports guy that can do a scope for your hip joint to release that area type thing, so you can move your hip better, and then hopefully mobilize the nerve so that it's not getting pinched. And the only reason I tell you this is I had I'll tell you a weird little thing about me that happened starting in December, as I fell forward with my right leg stretched out, and I fell over something at my knee, twisting my knee at the same time. Long and short of it was that the first injury that I had, it stretched out my hip. I had a certain type of hip arthritis, and I did have hip surgery, but my guy left me tight there. He didn't release it at all. And so I was having problems for several years. It was actually getting worse. That fall stretched that out. And so now I walk better at my hip. And I'm not going to go into my knee problems. That was a whole separate issue. But what I'm saying is that I used to have a lot of tingling that went down my thigh and into my big foot, my big toe area from that. And now I don't. And so what I'm saying is you may be able to correct part of this with talking to the right people, but you're going to need, if you end up with our arthroscopy, then there's a lot of sports guys in LA. You're going to find it. You're going to find one anywhere. I won't say anywhere, but there's a really big orthopedic groups there in LA.
Yeah, unfortunately, I belong to Kaiser, but
well, even Kaiser has people that can do hip arthroscopy. The problem is my brother has Kaiser, and they wouldn't do hip arthroscopy on him because he was too old. And I'm going to guess that you're at least as old as he was when they told him that. So you're
I'm 70. I'm 72.
No, he was like around, he was like around 60, I think, at the time. So yeah, you're kind of past what Kaiser will allow. But if you see a doctor there and you can figure out exactly what's going on, and if you do need that hip arthroscopy thing, you could theoretically, go out of Kaiser for a little while and come back. So that's an option.
Thank you. How do you spell that word? Hip what?
Arthroscopy?
Yeah.
Arthro, ARTHRO, stands for joint. I think it's Greek. And it stands for joint. Scopy is vision. So arthroscopy, looking into the joint. And so it's where you take a small tube, stick it into the joint with a camera lens, and you can look around. They have really tiny ones or pretty big ones. Like I was telling the other people about, they have scopes now for the spine as well.
Thank you.
Wow, excellent. Thank you, Lois. Maureen has her hand up.
Yeah, I wanted to ask you, do you know a Ron Waters? He was Ron Waters. He's an orthopedic surgeon in I guess in the Los Angeles area. Ron Waters.
No, I don't. I personally ended up with, I guess I was short, I was like 62, I guess. not even, I was 61. I injured my shoulder, but I kept working because if I don't work, I don't get paid, kind of thing. And finally, the pain was too much, and it turned out that because I waited so long, I tore it again. Then I was in a car accident and I tore it again, but then I needed a spine surgery. And then after that, it was just I had 11 surgeries in 4 years. By that time, you're no longer a surgeon. And I was already 65 by that time, past that. I had worked for myself. And so to get back into doing surgery, I would have had to belong to some work for like Kaiser or Sutter or somebody like that to be able to get back into it, because you need somebody to look over your shoulder for a while. And being on my own, basically nobody wants to take the time to do that. So that's why I'm no longer doing surgery.
So
But
the other question was, you know, now that I'm not walking anymore, and all my life I've always been wearing flats, lace up shoes, maybe a little like a Mary Jane in my much younger day. But now, I go to put my foot into a heel and my feet won't bend to get.
yeah. Well, again,
Surgery is something up.
I would not do surgery for that. You're asking for trouble.
Do my feet not bend because of the triple arthrodesis?
Oh, yeah, absolutely. If you've had triples, forget it. You're never going to have your foot bend down. No, absolutely not.
Okay, thank you.
Maureen, when I put my feet into my boots, they don't bend either. That's why I have the boots, but they just sit at the heel.
I have this picture in my head, Mona, and it's a pretty picture.
Who else has a question? Roland's
calling there.
One last thing, and before, I want to thank you very much. You're full of knowledge, my friend. One thing, my hands, because my wife is deaf, so I speak with my hand, and I'm so scared to.
You're not Italian?
I'm sorry?
You're not Italian?
French people speak like that too. You're going around,
okay,
up the stairs, down the stairs. But my wife being deaf, I have to use my sign language.
Yeah.
So, but I find holding something like a golf club or something like that, I can't do that no more. But my fingers work very, very well. Is that going to deteriorate? Should I worry about it?
Well, let me ask you, why can't you hold a golf club?
I'm sorry?
Why is it that you can't grip a golf club?
Because it's a slight grip that you put on, and every time I take a swing, the golf club goes further than the ball.
So you're okay. Let me ask you this then. Can you, if you're just making a fist, can you bring it all the way down like this?
Yeah, I can. But my problem is, you know, at the doctor, they got these little things that you squeeze and they tell you how many pounds. Okay, this one here doesn't have quite a half a pound. And this one here is about 3/4 of a pound. And this.
Wait. That's it?
That's it.
You're never going to swing a golf club and hang on to it with that.
Okay, I used to, like up to.
But I'm just telling. So again, you should, if you really want to find out why that is, you're gonna have to see a neurologist to find out whether this is part of your polio or some other problem. Like I was, I can't remember, who was I talking about that?
Yeah, I heard about that.
I was talking to Flora about that.
Yeah.
So there's many things that you have to deal with when it comes to the nerves and the muscles. It's not just, but your joints are working, so that's okay. But if you only have not even a pound of grip strength,
yeah,
you're never going to swing a golf club with that.
Yeah.
It's just not enough.
Yeah, I know golf course.
Find out what's causing that.
My worry was my sign language. I don't want to lose that.
Yeah. But I'm just saying, grip strength is usually from the bigger grip strength is from the ulnar nerve. You have any numbness or anything?
No. Well, tingling in the right Fingers,
you
not
go.
the thumb, but the fingers.
Well, the thumb, typically its tingling is most commonly carpal tunnel.
Okay,
But and that you can get some grip loss with that, but not as much as something that is more up towards your elbow.
okay,
So if you are having a lot of grip strength loss, then you need to have that checked out.
okay. All right, thank you. You're, Jim.
Who else has? a
Thank you for inviting that man. He's a good man.
Yes, yes. We have a few people who haven't asked a question. Chuck, do
Corey
you
has
have,
her hand up. Corey has her hand up, and now Denise.
oh, Gail. Yes, Gail. Oh, you're on mute. No, you're still on mute. There we go.
Hi. Dr.
Hi.
Eric, I wanted to ask you, you said some really interesting things that I never heard about is tightening of ligaments. So I think a lot of us with our malaligned bodies due to our muscle weakness, I don't think they ever did those kind of surgeries on us really. Right? But is there a window of time when that can be done?
What are you talking about?
Like if, let's say you twisted your ankle and you tore a ligament and
Well, no, actually, so the optimal thing is if you twist your ankle and sprain it, that somebody puts you in a brace and allows you to a functional brace. It's been shown multiple times on multiple studies that a functional brace allowing some motion, but it's stable, is better than casting and things like that in general. Surgery
helps with
as well.
circulation.
So but then later on, if it comes out that it's still loose, and especially in the ankle, there's a really, really good old technique that's been upgraded a couple of times called a Brostrom, BRO umlaut O STROM. And it's just a great, simple operation for loose, usually the outside ankles of the outside ligaments of the ankle to fix that. And it works really well. I used to love doing that one. But one of the things I learned, so when we talked about people having different laxity, this is another where I learned a lesson about laxity, is one of the first people I did it on had was very loose jointed, and they did not make any kind of ligament healing. So I went in there to look at the ligaments and there weren't any. It was just gone. And because we hadn't talked about me stealing a tendon from her foot, or in the old days, that's what you did. Later on, you can buy ligament or buy tendons from somebody else and you just set that up so that you buy one just in case or whatever. But the original operation just involves, it was described as you cut the ankle capsular ligaments in a sort of a curvalant, like an arc, and then you cut off a little bit and then you sew the arc together. To me, that made no sense. Because most of the people that remain loose are loose jointed to begin with. So I would cut that and then I would fold it over so that I had a double layer, rather than, so if you're a tight jointed person, like I think it was Maureen was tight jointed and something like that, you end up, you have a ton of ligament left there. You can go in there, shorten it, whatever you want to do, and tighten it up, and no problem. But more often than not, people that have remaining loose ligaments don't make enough scar tissue. And so you have to then you might have to rebuild the ligament using part of a tendon from somewhere. And you then do an anatomic reconstruction. So the Brostrom plus the augmentation with a tendon through the bone is typically the way you would go about it. Nowadays, you might use a suture anchor instead of through the bone. The old days, you would just make a little tunnel through the bone. Nowadays you use a suture anchor, but these are all, that's really good. I don't know. I always like to do those procedures.
And what about in the knee? Because I know I've had a lot of torn ligaments in the knee and they just never done anything. Now my knee is drifting into kind of a valgus posture, and I think they
Your
want to do it.
valgus.
Mhm.
So if you're valgus, that usually means that
I mean varus, yeah.
okay. Well, that's
No,
more
no,
common.
valgus, toward knock knee, right? Yeah.
What?
More knock knee.
Knock kneed where no, well, valgus is knock kneed.
Yeah, that's what I
Varus is bow legged.
mean. Okay, so valgus then, yeah.
Okay, so you're so what can happen, and again, without x-rays or things like that, well, it starts off with you wearing out the cartilage, both
Yes.
the articular cartilage is on the bone and the meniscal cartilage. But if you're really valgus, then
It's mild.
again, I'm postulating here is you may actually have had an insufficiency fracture. Typically, it involves the tibia, what's called the tibial plateau, which is the joint surface of the tibia at the knee, and you can get depressions in that due to you coming down hard on it, and it just breaks it a little bit. But because you may have pain for a while, but over time it sort of sinks down and it finally heals, let's say. But by then you're in valgus. And I think I told you about my injury in December to my hip. Well, it turned out that I also injured my knee, and I think I had a small injury to my tibial plateau that it healed up reasonably well, but it took a couple 3 months before the pain was kind of gone. And so it's just, so anyways, that you'd have to get x-rays and things like that, and maybe an MRI, but chances are you probably have arthritis and a small depression fracture of the tibial plateau on the lateral tibial plateau. Now, if you have that and is it painful?
It comes and goes. It feels very unstable and very loose, and I re-injure it from time to
So
time.
there are some.
Mhm.
How old are you?
I'm 72.
So if you're going to see a doctor at 72 with this kind of problem, they're going to want to do a total joint on you.
I know. I don't want to.
Well, they do make. We'll say this, and I don't know why more people don't use it. They have what are called not hemi. They call it unicompartmental arthroplasty, and it's really half the joint. There's 3 joints in the knee: medial, lateral, and the patellofemoral. So, in your case, you could have maybe the lateral joint with a unicompartmental, and it'll be metal and plastic. It's a quick operation. Takes, I don't know, I think it was taking me about like an hour or so to do it like that. And you get a really good result, and it only takes about a month and you're feeling good again, kind of thing. And I don't know why and there's some really good.
What's it called? What's the name of that?
Unicompartmental.
Okay.
One compartment. The 3 compartments of the knee, so they call it a uni. Compartmental. Anyway, it works well, and I've even there's a surgeon in San Jose, California. He was a sports guy, and he was doing them for both sides as opposed to a total. And it's a good operation, and it turns out that longevity wise, assuming that your other joints don't go out on you, you decide to do something with them. But the unicompartmental versus the total at 10 years is basically the same, except that actually the uni was slightly better than the total at 10 years. So it's something to think about.
Question though, as far as like a rehab, just cutting through with muscles that are already
rehab
weak.
is way less for a uni than it is for a total.
As a polio patient that already has.
Well, that part I don't. You'd have to do the whole exam, So I'm just talking about just for the knee.
Yes.
If it's
That's what
just wobbly
scares
back and forth, you know, you trying to do collateral ligaments is kind of a pain. You're better off fixing the bony part, like with some sort of prosthesis.
Mhm. Okay,
Is
thank
if you have loose ligaments, you're probably a loose jointed person to begin with.
If what?
Harder to fix.
Right. Thank you.
Mike
Thank
here
you.
has got his hand up.
Yes. Who's that? Mike? Mike, you have your hand up?
I don't think he's talking. I can't hear him.
Yeah, I'm here.
Oh, is it Mike or Cora?
Well, I
Cora
don't
has
know.
her hand up. Mike, did you?
Corey's got her hand up
Mike
too.
was waiting.
Yeah.
Okay, let's start with Cora.
It's Corey and
Corey.
Denise, and then Mike, you have to fix your microphone because we don't hear you. So maybe sign out and come back in.
Okay, Corey.
Well, I'm really glad to be here and be with all of you brave people. I'm just getting used to having so many problems. I didn't used to, so I'm kind of a new arrival here. So I'm getting used to dealing with not having my body the way it used to be. I'm a breast cancer survivor, so that adds in some complication because I've been through chemo and I've been through radiation, and that does a number generally on you. One of the things that I want to do is a hip replacement in the leg that did not have polio, which is very rigid now and painful. And the other thing that I wanted to possibly at least touch on this evening is that I'm on a drug. I'm on an aromatase drug that usually is hormonal treatment against estrogen. So my body makes none anymore. It's what my cancer was living on. So I take something to suppress it, and it has a lot of side effects. And one of them is trigger thumb. And I've had 2 shots in my left and 1 in my right. I'm right-handed. And I know if you go past 2 shots, because they get stuck, you know, I mean, they pop and then you can't, you know, open them up anymore. And, you know, I can't get dressed. I can't do anything. It's like when you don't have thumbs, it's pretty serious. They're sort of okay at the moment. They swell up, especially the right one at night. And then I hold it above my head, like to hope that the liquid drains down against gravity. I'm like lying in bed when I wake up and I put my hand up in the air. That seems to help. And I massage, and then how would I say it? Mechanically hold the lower joint and stretch. I've seen all this stuff online. And I'm just
Stretching
wondering.
Stretching backwards is
What?
Having your thumb go backwards that way, yeah, is much more important because and holding it there for at least 10 seconds per time is what you're going to need to do if you're going to. So what, like you're talking about, the fluid gets into the tendon as well, and so the tendon swells. What you're really trying to do is sort of squeeze the tendon out by going backwards. And if you're very like OCD about the stretch, yeah, then you may be able to reduce the swelling and whatnot. But you have to do it for 10 seconds each time. No, like 1, 2, 3, 4, that kind of thing. You can't cheat, and otherwise it won't work. Okay, that will help. But if you're getting a shot, in my mind, do you know what kind of medicine they gave you?
Cortisol.
Yeah, but I mean, not which type of cortisol. Was it clear or was it white?
I couldn't see it. It
Okay.
went in the needle and
Well, but in the syringe, usually you can see what it looks like in the syringe.
I think I would turn my head away. It was very painful. Yeah.
All right. Well, anyway, in my mind, there's I won't say there's only one, but there's only one good one for that. It's called Kenalog is a brand name. Triamcinolone, I think triamcinolone is, but it's very small particles. It's white. And if you you don't even have to put a whole lot of it in there, but you got to get it in next to the tendon. So which means that the tendon is inside a tube. You have to go through the tube and into the tendon, into the sheath, but not into the tendon. Okay. So that I mean, takes skill, but if you can do that, then you can get we're using the triamcinolone, Kenalog is the brand name. You can get a really good result. And if you cannot get a good result with that, then almost for sure you're going to need surgery, because it just, I mean, if you're doing all the right things for rehabilitation and you get a good shot with the Kenalog and it doesn't work, you're one of these people that's just, you're almost for sure going to end up with surgery. The surgery itself should be relatively simple and easy. The problem, and I don't know, I've never had this experience before, but I had to oversee somebody's result where they actually took out what's called the pulley, which is a strong ligament-like thing that helps the tendon stay where it's supposed to be. And this guy cut out the part of the pulley, and it just created more scar tissue for this person, and they ended up with a bad result. And my opinion was, don't do that operation for her, type of thing. But if you're gonna do, there's just a pretty easy way to do it. But I would try doing the exercises first, and if that doesn't work, you could always do them forever, type thing. But and then if you need you go find yourself a nice hand surgeon. Don't do. I would say that you need a qualified hand surgeon to do it. But even then, talk to them, make sure they're just doing a release and not an excision of the pulley.
A release and not an excision.
Yeah. Now, I've never seen anybody do an excision before, but this guy made a mess of this lady's hand by doing excisions in place, I mean, that you don't need to do. And I believe this is here in the States. I believe it was a way of making more money. But, most hand surgeons would not do an excision, I don't think. But
Mhm. Yeah, I'd like to also ask you, thank you. I'd also like to ask you, do you have a favorite? Everything, somewhat, not everything, but some good stuff is actually on Zoom, online, podcasts, whatnot. Do you have a favorite place for the hand exercises? Because I've seen a million of them, but I'm wondering, you said I can do them forever. At the moment, I
well, it
don't.
depends on what you're trying to exercise. Some things you cannot exercise.
The
and some
thumb.
things you can.
Mhm.
You have to know the diagnosis. And that's the other thing is I see a lot of, I read a lot of medical records. I get hundreds of pages. There used to be thousands of pages of medical records. And now they because they changed the law here in California, I only get, anywhere from 100 to 200 to 300, maybe as much as 500 pages. But most doctors that I read do not make an adequate diagnosis. They kind of fake it, and it's like, I say they got, thumb pain or something like that. It's like, well, what part of the thumb? What piece of the thumb is the problem? And they don't tell you. And so when I come by and I tell the patient, well, I might suspect that this was probably what they're talking about, but they didn't say it because this is also has to do with legalities. So for me, I say, well, this is the part of the thumb that I see that needs something. And the fact that no other person said that before this means it's part of your case now, which then means that I can associate it for treatment type thing. Whereas they may have had a prior work injury involving the hand or whatever part of the body it was. But if they don't make a diagnosis that's adequate, then I look at it as fair game for me to make a good diagnosis and specify a treatment for that injury rather than, I mean,
Fixing another.
they're just, people are just, they, are very wishy-washy about how they describe stuff, and they don't want to, I have people that need translators. And I actually had a translator that said that she watched doctors not even touch the patient. I mean, how can, as an orthopedist during COVID, it was like, I cannot see anybody because I'm not going to do Zoom to try to figure out what's wrong with somebody. Like right here today. I mean, there's no way I can tell you exactly what I think is going on because I can't actually touch you. But so for 10 months, I didn't treat patients. I didn't evaluate them at all. But once once we figured out what was wrong with how you got COVID, I bought some great fans, air purifiers. And so I was able to go back to my office, and then the vaccines came out. And so, basically I was ready, but I used to suit up, mask, helmet, gown, all this kind of stuff when I first went back to work because I didn't know, but finally we got it figured out. And so I was, much more comfortable just actually seeing people and treating them like I used to. But you need somebody that will touch you and figure out what you actually have, and then go from, like I could tell you from just your trigger thumb. I know trigger thumb. I know how to deal with it. But all other things, there are things that you need somebody that's willing to actually figure out what's wrong with you. And that's the hard part apparently nowadays.
Yeah, because I basically had someone who just said, exercises are useless. You've come here 3 times, go get shots. And I went and got
Yeah.
shots. The guy,
Yeah.
I mean, my whole hand was really bruised and the needle was moving around and I could feel it jumping.
Okay, well, it doesn't sound like, I mean, I
It was
will say
horrible.
one thing for myself, that I'm pretty good with my hands. Now, and I have a good tactile sensation, such that I was able to do things that other people now use ultrasound to look at. But you need somebody who's going to spend some time. And unfortunately, I don't know, in the United States, you have the electronic health record, and almost no doctor is willing to take the time to evaluate you because they have to fill out this electronic health record, but so they can get out on time and see their family or do whatever else they want to do. And so fortunately I don't have to do that. I never did it. I don't intend to do it. Not the way I work. My brain only works one way, and that's not the way it works.
My other question has to do with, I'm going to see 3 different physiatrists. I'm interviewing doctors. On my insurance, I'm allowed to have second and third opinions with people that are in my network without a referral. It's absolutely amazing. And I'm really grateful. All 3 of them tell me they quote, no polio. And each one will look over me for about an hour as an intake. What should I be for looking at the leg that did not have polio originally, but is now almost completely rigid in pain with a very eroded hip joint? And one of the surgeons
yeah.
said, and I want to see if they can prehab me, look over whether I can get through the surgery and then be there for at least guiding me somewhat for the rehab, because the other leg, the polio leg, is very weak. And so how I'm going to rehab when I can't walk that well on the other one, and that's new.
Now so when you have a total hip, you're going to get up out of bed the next day and they're going to start you trying to walk the next day.
Mm-hmm.
So, or at least they should be doing that.
Mm-hmm.
How old are you?
I'm 70.
Okay. So chances are they're going to put in, I mean, I won't say absolutely, but the more common thing is to put in what's called a cemented hip. And those are as strong as they're going to be the day that they put it in, basically. And so once, other than, that it turns out there's a recent evaluation where they evaluated anterior approach versus posterior approach. And there does not seem to be a significant differential in the overall outcome. There is a little bit longer learning curve for the anterior approach, but otherwise doesn't seem to make a lot of difference. Scheme of life type thing. You need a good hip prosthesis. You're going to be low demand, so they're not going to give you a really high end type prosthesis, and meaning uncemented, that kind of thing. They're going to give, I'm almost for sure going to give you a cemented prosthesis, and they work great. You can have one of those last you for 20 years or so. But there probably is a slightly increased risk for dislocation on the posterior approach. If there's things you don't want to do and things like that, but if they're doing it well, then they should do all the releases that you need during surgery to balance the ligaments and things like that. Sometimes people have what's called a protrusio hip, where the hip socket is deeper into the pelvis than normal. So you need to kind of take down some of the bone that grows on the outside there so that you have a relatively normal range without risking dislocations and things like that. So if you get a good hip guy for your hip, you should be okay. But for pre-rehabilitation, it's going to be pretty uncomfortable and may not be of great benefit for your bad hip. But I'm not sure what's wrong with your polio leg, whether you're just what we talked about before, whether you're a tight jointed person. And again, this tends to go along a little bit with trigger fingers and things like that, that slightly more common where you're making better scar tissue and stuff, because it's usually what are called adhesions, which is a light scar tissue that are sticking the tendons to things. But be that as it may, rehabilitation post-operatively may be more critical than preoperatively, because unless you're loose jointed, if you're not loose jointed, it'd be very difficult to get the joint to move without surgery. So you don't want to necessarily expect too much from a pre-op, other than your heart, your lungs, and things like that, and then finding a way to exercise you that you are capable of exercising to build up your core strength, rather than that kind of thing. So
By core strength, do you mean abdominals and that?
well, yeah, abdominal, heart, lungs, that kind of thing, where you're actually you can. The problem is with a bum polio leg and a bum hip on the other side, you're not going to be able to do much of any kind of real rehabilitation until you get your hip fixed. It's just, it's going to be too painful for you. So you're kind of stuck between the proverbial rock and a hard place for that.
Mm-hmm. Is it a problem if I'm taking also against the cancer something called Zometa, which is ultronic acid? It's an infusion in my veins twice a year, and it produces I'm sorry.
You have osteoporosis, and it builds bone back.
Mm-hmm.
That's a good thing.
Say
It's
that
a good
again.
thing for the hip,
The good thing.
because you want osteoporosis. Even, if it's severe osteoporosis, even a total hip, sometimes the bone can break around the. It doesn't happen very often, but the more osteoporosis you have, the more you can develop what are called insufficiency fractures around something that's hard, that you push it hard for whatever reason. Then you can bend the bone. Actually, your bones actually become sort of not so much brittle, but bendable even sometimes, depending on where the bone is, what part of the body it is, and things like that. There's, I know it sounds weird, but I see it even in younger people, but they've been on disability for a while, and they end up, look at their bones. It's like, well, how did they get this, which is an insufficiency fracture? That's the other thing. The radiologist, oh, it looks fine, looks normal. But that's why I always look at all the x-rays, MRIs myself, because I don't believe a radiologist.
Mhm. So that's something to discuss with the physiatrist and the surgeon, right?
Yes, those are things to talk about with them so that you can get an idea. But they're going to have to assess you to figure out what you could or couldn't do.
That's why I'm going, because I also have venous insufficiency. So I have to pull up
You have
these
what?
venous insufficiency.
Venous insufficiency.
Yeah, so
You're getting blood clots in your veins?
At this point, they're in pretty good shape, but I'm religious. I won't get up in the middle of the night to go to the bathroom without pulling on my compression stockings. I mean,
Okay, all
I
right.
won't be upright without them, and I'm worried about
Yeah.
from the hip
Well,
replacement.
so total hips are the problem with total hips is you're much more likely to have a venous blood clot, potentially, pulmonary embolus type thing with hip surgery. So you're going to need a lot of people involved in your case when you have your hip done.
What sort of specialist should I be trying to put together to help me?
You need to talk to your hip surgeon, and your hip surgeon's they're gonna have their own favorite people to deal with probably, but you might need an internal medicine doctor to look at your clotting factors and things like that while you're clotting so much. There's a lot of things that go into it, and stuff that I'm not going to know about because those aren't my specialties. But you don't want to, if you're really thinking about this, then you're going to need to talk to your doctor to make sure that they're covering all bases.
Are there any other bases that you can think of that I should bring up? And thank you for answering
I
all these.
would this is something without knowing your whole medical history, it's kind of hard to think of bases that are going to make sense. So again, find out if you start with your PCP and see if they'll talk to you. Go to you have your rehab specialist. They actually have a fair amount of internal medicine background in addition to the rehabilitation stuff. So those are people that are good to talk to for a lot of different things. And then the orthopedist is going to be, their job is to sort of be the conductor of your surgery so that they get everybody on board with what you need to have done. And so these are things those are who you need to talk to. I'm not going to be able to really give you a lot of clues without knowing a lot more about you.
Thank you. You at least confirmed what has been a suspicion that's kept me from doing this for about 1.5 years, almost 2 years, because the venous person said, go ahead and have the surgery. The orthopedist said, you'll be fine. Let's do it next Wednesday.
Well, then if the venous person said you're okay,
You should have done it.
I'm assuming that's an internal medicine doctor.
No, it's a venous surgeon.
Oh, a venous surgeon. Talk to an internal medicine doctor who specializes in hematology and see if there's anything, because there are weird genetic conditions that can predispose you to clots and things. And you just want to make sure that you don't have any of those zebras running around, that you have a regular, straightforward kind of thing. But if you're having a lot of venous stasis problems, it could just be the fact that you're not moving around much, you're sitting around a lot more, and you're the right age, and maybe you need to be on blood thinners to begin with, that you're not, or certain types of blood thinners and that kind of thing. But those are all things that your rehab person and maybe an internal medicine hematologist would be able to help you with.
Thank you very much. It definitely confirms the fact that, all these scattered specialists, there's been nobody in charge except me, and I'm not a doctor. And
Yeah,
as a
I'm telling you that it's modern medicine. It's just not, it's not what you used to have.
I
It's-
sometimes think of just not having the surgery and just living with my hip the way it is. Because
well,
I'm
that's
so scared.
that's something you have to think about. But if you go through the work of finding the right answers, the surgery should be, it's not a big deal in general, but all the potential complications can be a big deal. And those are the ones you have to cover. Okay?
If you
Thank
ask,
you
if
very
you
much.
ask all the same questions you've asked today, I'm sure you're going to get some good answers.
Mm-hmm.
Yeah.
Thank you very much.
You're
Between the thumbs and my polio leg and my other hip, it's been kind of like, I've been taken over by these issues, and I haven't been able to get to first base with any of them. But I finally figured out that there are also physiatrists, and they generally are looking at this whole situation more completely. So I don't want to take up more of people's time, but I really heard what you had to say, and I took notes.
Okay.
Thank you very much.
You're welcome.
Thank you. Mike, I think Mike just left, eh? He was trying to say, we have just a couple more minutes. We've really, Eric, you have been wonderful. Is there someone with a pressing question? Lois?
Laura.
I just wanted to say thank you.
Lois.
Oh, that's nice.
Dr. Eric, quickly,
Sure.
2 years ago, I twisted my polio leg. I started having pain and a little bit of swelling. I had an MRI, and the MRI says the following. The longitudinal split tear of the peroneus brevis tendon posterior to the lateral malleolus with associated peroneal tenosynovitis, as described above. No fracture, advanced arthritic changes, or evidence of acute ligament injury. With that tendon tear, I used to work with a physiatrist. He told me to wear an ankle brace. So I used a AirCast ankle
Okay,
brace.
so do you
on
remember
and
that?
off.
Do you remember that figure 8 brace I was talking to you about?
Yes.
Okay. Now I can't say absolutely without checking you, but I actually have a patient with similar kind of problem, and she's the one that I told you the anterior talofibular ligament has been out for years now, and that she developed that, not the brevis but the longus, and then her doctor went in there, cleaned out her ankle with a scope, and then debrided the tendon, but he didn't do any kind of repair to it. I can't say absolutely that, but when and they're not real common, but when I had one of those, basically I did sort of a sort of like a shoelace type of repair inside the tendon, and just to give it some strength while it was in the process of healing. But the other what in fact, I just finished the report on that. I said, this lady's had this problem since I first saw her. Nobody has fixed this ligament. And then she's the one that not only was the lateral ankle ligament loose, but now she's getting looseness in the medial ankle ligament in the same place with the foot down just a little bit, not neutral, but or the foot coming down a little bit. Both sides were loose. And I said, can you just fix this? And maybe she can get better, kind of thing. But, I just sent that out like last week, but it's
I
just
have good idea.
the
I'm sorry.
figure eight, if you're going to do a brace, the The one that you're talking about is not good for that ligament. You got to have the figure 8 brace. It's the
Okay,
only one that really works for that ligament.
figure 8 brace. Okay. What do you call it? I have good days and bad days. I can be without the brace for a long time. Then when I feel the pain, I will wear it, and maybe in the next 2 or 3
Well,
days,
but
it
see,
will feel better.
that's the problem. Is the only reason that tendon is having a hard time is because it's trying to do the job of the ligament. And unless you
see.
support the ligament, you're always going to have that problem, or it'll get worse and really tear on
So,
you.
so the recommendation then is to have a surgical intervention.
Well,
on
the
it.
recommendation is to support that ligament, whether you fix the ligament or you wear a brace that holds the ligament
all the
stable.
time. Okay.
Well,
I
if
have
you're,
one more thing to ask you
that's
quickly.
basically it. Yeah, you know, you don't know that I mean, you could just step sideways and all of a sudden it's like your ankle starts to flip out on you. And when
Mhm.
that happens, that tendon is going to try to stop you. And if it's hurting, it's not going to be able to stop you. And you may be starting to have a fall or something. So
Oh,
these are
no.
the things you have to deal with. You have to be aware of it. And
Thank you very much. I have not really seen an orthopedist because it's on and off pain. It's not really that bad. But with your advice, I will go ahead and see an orthopedist. And I
Yeah,
have
well,
one more thing. Please explain this
you
to
need
me.
a foot and ankle orthopedist. I'm not sure where you
Oh,
where
yeah,
you
yeah.
are, but
Okay, Floor, let's let Joyce talk
need
first,
in
and then
Okay.
the
we'll come
United
back to you.
States, you need
Joyce?
a foot and
Joyce,
ankle
okay.
orthopedist.
Okay, a foot orthopedist.
Foot and
Yeah, I will
ankle,
Joyce?
find one.
foot and ankle.
Foot and ankle.
Yeah,
Okay, thank
there's a
you.
specialty.
Yes, I understand. Yeah. Not a podiatrist.
Well, this lady had a podiatrist, actually had an regular orthopedist who didn't fix the ligament. And I've had another person who had that problem, and the podiatrist says, oh no, he needs a calcaneal osteotomy for his flat foot, except that he didn't take care of the problem that caused the flat foot. So I have a
Okay.
disagreement with a lot of current doctors.
No, I don't want to go to. I never would go. Never went to one. But
All
thank
right.
you for the advice, and I will do so. Thank you.
You're welcome.
I have a comment. I had a failed arthroplasty of my polio hand. They took an old tendon that was weak and they tried to fashion
Your thumb?
a new joint around here.
Your thumb.
I cannot bend this joint.
Yeah.
And this is numb because there was maybe a slice of something. I can't tell if it's hot.
Yeah, if it's numb, they cut a nerve. So
I think, so there's nothing that can be done with this or.
So you need, for that, you would need to see a hand surgeon.
I went back to him and he turned his back and he walked away and I have not been able to talk with
Well,
him.
you need to see a different one then or something. I can tell you that as a young hand surgeon, I did that arthroplasty and I rapidly became dissatisfied with it because it works okay for people who make a lot of scar tissue, but if you don't make good scar tissue, forget it. It's going to fail. And so I stopped doing that operation basically. And I actually made up my own operation to fix the ligaments for that one. And it works, but I have yet to publish it. I need to get my information and get it out in the information. I tell people about it, but I haven't published it. So, but it works well. But for you, if you're missing that bone, you're going to need a different kind of an operation. It's a reconstruction of some sort. And there aren't any really good ones for that.
I drop everything and I don't have full use of this and
Yeah.
I can't play the piano because I can't reach the
Yeah.
octaves and.
No, it's unfortunate, but that's why I stopped doing it because there's no good reconstruction for once you have that fail. It ends up being, it's really a bad, I don't know. I just refused to do it after that. And it took me a while, but it took me about 10 years to come up with a decent alternative to doing those things. and it
I
works
sort
well,
of
but
thought myself that maybe it was the old tendon from the polio side. I don't know.
no, it's the tendon. That's just it's a really old operation. It's been around for more than 50 years, probably since the 1950s.
My
And
mistake.
in general, I was not impressed with it. When I was a resident, we did it, and I just have an aversion to doing that kind of, because there is no once you've done it, there's no going back. There's no way of going back for that particular joint, at least not now. I mean, in the hip or something, you can put a total hip, or they have these really wild reconstructions, these fancy total hips that you can put in that you're missing bone or something like that. But for the thumb, the basal joint of the thumb, nobody's come up with a really good idea to reconstruct it once you've taken out that bone. So
Well,
nothing that works well, let's say it that way.
I wish I had stayed home that day.
Probably, yeah.
Thank you, Dr. Eric.
You're
Appreciate it.
welcome.
Thank you so much. I
Are we done?
think we've had.
You wore me out. You wore me out.
I think we did. I think we did. You have been absolutely marvelous. The questions that we put together for you were just extraordinary. I recorded this and I will send it to everyone so that we can hear them again. And if you ever have any more energy, Eric, we'll wait quite a few months. We'll wait till after the
So let me
summer.
recuperate, huh?
So you can recuperate. And I think that everyone got some excellent answers. Yes, absolutely. It's
Well, I was
marvelous.
very impressed.
Very impressed. Thank you, Tootie. You did a great job. This is one wonderful son you have. And so much good information on what we can do and what we shouldn't do. And
yeah, that's very important. And I
Yes.
remember hearing it discussed, I think it was on this meeting or one of the meetings about the what Eric was talking about, that the current medical care is not very good. And I think, I don't remember who it was, but either somebody had read it in the news or anyway, we talked about it for, a minute or something, but.
yes,
It just seems like I mean, electronic health record makes a lot of sense, but without being able to have the equipment to allow somebody to do an adequate exam, provide an adequate answer, and yet still be paid for your time, without having to, go over what you're going to get paid for. People don't want to. I mean, when I worked for Kaiser, this is many years ago, I was the first person there and I was the last person to leave.
yeah,
And it was just because I saw twice as many people per day as my boss. I saw 1.5 as many people per day as the usual person there. And I had like 2 surgery days as opposed to 1 surgery day for the other people, just because I don't know. I mean,
So he got fired.
yeah, I got fired.
exceptional.
My boss did not like to be shown up.
One of the things I did notice is that doctors don't touch you anymore. It has nothing to do with COVID. They just don't. There's no hands-on. And
like I said, I was kind of shocked to say this. The lady she was a translator. She said, I said, look, I need a little bit more time, blah, blah, blah. I take nowadays, because I'm not treating and I'm trying to figure out, I have to be the arbitrator between the insurance company and the judge and whatnot, and the doctors. And so I spend a lot of, I take, usually I'd say 90% of the people I see them for about 2 hours. Some people I might see only for an hour and a half. but I like last week I saw a lady for 3.5
I
hours.
was gonna say, I've heard you talk
So,
about
you know, but
3
it's,
hours and more.
you cannot do that in private practice or any kind of group practice and expect to get paid. It's not going to work that way. You have to pick and choose. But because I see people, I got to do an exam from the neck to the toe sometimes. So I do the neck, the thoracic spine, the lumbar spine. I do the upper arm, the upper extremities, the lower extremities, the hips, blah, 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 you know, the whole thing. And it takes you, I mean, I was doing a report last night and my exam, single space, except for the paragraphs, was all 2 3/4 pages. I mean, that nobody does that. I mean, but I look at it as I don't really care. I like figuring things out, and so
Doing a
I
good job.
just I'm more or less semi-retired. I just want to be able to make enough to keep my office going and give me a salary at the end of the year and that kind of stuff. And so, but I enjoy it, so I do it.
Well,
Well,
really,
his brother has had that major back surgery. And
yes,
he's going for a second visit for, it's been what, 2 months, I guess. And so I said, Ted, do you have your list of questions? The last time he went, he had a list of questions, and the doctor, when he came home, he said, well, I didn't get to ask them all. And but
They don't have time.
so anyway, his partner Maria said, well, he doesn't like to talk. The doctor doesn't like to talk.
Yeah.
And I said to her, I said, well, because I talked to him once, you know, I called a report, and I said, well, tell her I think he's a very nice man, and then he'll talk to you. And I don't think she thought she was taking it seriously. I was just joking. He's not going to talk.
It turns out that I have a bunch of educators in my heredity, school
Oh,
masters
good heavens.
and
yes.
whatnot on both sides, you know, so and on my mom's side, and then on my dad's side, we have missionaries. So, you know, we have somehow I inherited. I like to talk and tell people what I think is going on, type of stuff.
Yeah.
So,
very good.
But if it wasn't for that, I'd just be like everybody else, kind of thing.
I'll tell you how he told me some years ago now, that when he was little, he would get up around 4 in the morning and go out. We lived near a bay in San Diego, and he would go out and hunt for birds and this and that and the other thing, and come back and get ready for school. I didn't know it. So he's been out learning since he was a very small kid.
Thank you.
Thank you.
All right.
well, Eric and Tootie, our heart goes out to you. You have been a wonderful, wonderful guest. This has been recorded. I will send it to
Good.
you both. And
Good.
I want to say thank you to everyone for this really excellent talk. This is the thing that people with polio have been missing all these years. And
Yes,
we didn't have someone to talk to when we were children. When we were children, they asked us what we wanted. And that's how I ended up with that button in my heel. And now that I'm an adult, they don't want to talk to me either. So we thank you from the top and the bottom of our heart for such a wonderful talk.
All right.
And you know, back in the day, an orthopedic surgeon took care of all your bones. You didn't have a pinky and a knee and an ankle guy. They did it all.
Yeah, but you can't know enough nowadays.
Well, we got by and we're here and we're still here.
And we're
Yeah,
still
but
here.
I'm just telling you, I was, for me, I did a hand fellowship. I did orthopedics first, and then I did a hand fellowship, and then I did about 25 years of trauma. So other than the spine, I pretty much fixed every part of the body at one time or another. So for me, that whole thing has led me to what I do today. If it wasn't for all those things, I don't think I'd be as good at what I do today as as I would have been.
And 11 operations, you're almost comparable to us polio
Well,
people.
that was only in 4 years. I have had over 20 operations.
Well, then you come very close to how many I had, because I stopped counting after about 27. That was
Well,
enough
Wow,
for me.
Yeah.
my God.
Yeah.
Did
But
you,
other than those 4 years, I've been pretty much working my whole life. So
did you
Yeah.
ever have polio? Did you ever work with people who had polio?
my residency hospital was the polio center. So and there was still some really old timers there that you could learn from, but no, I didn't. And we actually had leftover iron lungs in the sort of in the basement kind of thing. But no, polio was not something I really ever had to deal with. I did a lot of, my hand surgery was in Phoenix, and I saw 1 million rheumatoid people, which coming to California, I see a rheumatoid about once every 5 years kind of thing. There I saw 2 or 3 a day kind of thing. So it's a different, where you are, what you do, it ends up, you learn about certain things. And nowadays, just with the polio vaccine, nobody has polio unless you're, before that type thing.
Well, no, polio is still going around.
Well, but not in this country so much.
No.
So I mean, pretty much everybody gets the vaccine when you're young, and it saves you from that. But anybody that's early before the Salk vaccine came out, you're much more, and all of you appear to be in that age range. You're much more likely to be susceptible to the polio virus then.
Which, as lay people, us being lay people, what did you think of the questions posed to you?
Well, it's something it's just the nuts and bolts or the bread and butter, I guess, if you will, of polio. These are all problems that end up because of poor muscle function. And then for some of you, because that happened early enough, you also developed, you didn't have the stimulus to grow like a leg the same length. This finger is shorter than my other finger because I cut my hand as a 4.5-hour operation that I got to watch for 4 tendons and the ulnar artery. But because the ulnar artery was just tied off, this is the old days, my finger was it's a little bit shorter, and it's not as big a diameter. And for about 2 years, if I threw a baseball, that part of my hand just went like fire. But finally, the artery I got a bigger artery, and I was then able to do things with my hand. But my left hand is actually stronger than my right hand because of that, and I'm right-handed. So I kind of have an idea how it works. If you don't have the right equipment when you're growing, some part of you isn't going to grow well. And I did pediatrics. I did pediatrics at Children's Hospital in Philadelphia, but we had good pediatric orthopedists where I was working. So I got a lot of pediatrics over the time. So, which gives you a hint at least as to how polio works. Not the whole thing, but.
The doctor who did Eric's surgery on his hand said it was a kid, and he said, well, he'll be fine, everything will be all right, but he'll never be a surgeon.
Did you ever work on thalidomide babies, or were you not old enough at the time?
I'm sorry, what?
You ever work on thalidomide babies, or was that?
Thalidomide? No, that was before my time.
Okay. That was
That's right. Wow.
Yeah, there's some horrible things that go on in the world. So.
Yeah.
But this was a wonderful time, and we all really, really appreciate it.
I'll give him a reward. I'll ask him what he wants.
Give him a big kiss, Tootie. A big kiss.
That's it, Tootie. A big kiss
Maybe
and a yoga hug.
A yoga hug. There we go.
A yoga hug.
There's a good idea.
That's a good one. Well, on that note, I am
Mo-
going to say good night to everyone all
Good.
together.
Mona,
Bye-bye. Bye-bye.
Mona.
Bye-bye.
So great to see all of you and be with you.
Diana's calling.
Diane's asking a question for somebody.
Yeah.
Diane.
No, I don't have a question. I have a question of Mona, just a real quick question. It's
All right.
not
Okay.
related
Take
to
off.
today's talk.
All right. Bye-bye. Thank you.
But
Take care.
Mona, Sanjay